Hello, everyone. I was just saying to one of my colleagues that, many of the times that I'm presenting, it's in sort of a research conference context, and this is such a refreshing change to be in a room with people who are on the front lines, practicing and seeing patients. So I'm hoping to be able to impart some of the experience that I've had in our research lab as well as our clinic. And I'll be sort of presenting for a little bit, and then I have my colleague Rikard Wicksell, who's going to be coming up and presenting as well. So I'm going to be talking about fear and chronic pain, mechanisms and effective treatment. And I have sort of two institutions on here. Boston Children's is where I previously was, and a lot of the work that I'll be presenting comes from that. And Stanford is where I am now. So if you need to find me, that's where I am, not so far away from here. And the weather is actually better right now in Stanford than it is here, which is crazy. Okay, so I imagine, so in the room, how many of you actually treat children or adolescents with pain? Oh, yay, that's many more than I anticipated. So just briefly, I wanted to talk about, for those of you who don't, that chronic pain is a big deal in kids. And this is actually something that comes up a lot when I meet people. They say, oh, I didn't even know that kids had chronic pain. In fact, it's a $20 billion problem in the US alone. And about a third of children suffer with chronic pain. And 3 to 5 are pretty debilitated by it. And when we think about chronic pain, as you all know, it's incredibly complex with the sort of interplay of physical, emotional, cognitive, and behavioral components. So importantly, children ultimately grow up to be adults, which I imagine everyone in the room knows. And this is important in considering pediatric chronic pain and that prognosis. So for example, recurrent abdominal pain is something that a number of folks go on into adulthood to have psychiatric comorbidities, functional abdominal pain or IBS as adults, and they have sort of pain sensitivity or things like temporal summation differences. So their ability to sort of modulate or interpret pain signaling changes based on that experience in pediatrics. Pediatric migraine, many people develop migraine in adolescence, and about 51% of them, in a study that was done over 40 years, 51% continued to have migraine symptoms in adulthood. And fibromyalgia, that's another condition that many people say, wow, I didn't realize that kids or adolescents have fibromyalgia. And there was a recent study done by Susmita Kashkarzak at Cincinnati Children's that showed 51% continue to have fibromyalgia in adulthood that were diagnosed in adolescence. And complex regional pain syndrome is another condition seen in children, and about a third of those continue to have those symptoms in adulthood. So when we think about pain systems and how we're going to target intervening, there are so many physiological as well as psychological systems at play that focus on things like your sleep-wake cycle, endocrine system. All of these things are disrupted in the context of chronic pain. As a psychologist, most of my work has focused on sort of the psychological systems, but they're all interconnected, and they all sort of feed forward into sort of your brain circuit networks and ultimately what we see in the clinic in those behaviors. And of course, in childhood, you're also dealing with development. So that sort of overlay of puberty, hormones, and all of those contexts that shift and in some ways make a child more sort of plastic in their nervous system, more resilient in the context of pain, but